Ladies and gentlemen, very good morning to you. Allow me to welcome you to a roundtable organized by Zdravotnický deník dedicated to secondary use of data in the Czech healthcare system. I would like to thank the Institute of Clinical and Experimental Medicine, IKEM, for allowing us to meet here. I would like to thank Professor Markéta Haluzík for providing the auspices to the event. Professor Haluzík is the Senior Consultant of the Diabetology Center of IKEM. I would like to also thank the Association of Innovative Pharmaceutical Industry for organizing this event. Our event is dedicated to secondary use of data. Firstly, we'll speak about the European health data space, secondary use of data, then good practice of secondary use of data in the Czech healthcare system. And in the third part, we'll discuss the current situation, the secondary use of data in the healthcare system and prospects for the future. Then we'll have a discussion. Before we start, I would like to ask those of you present in the hall or following us online if you would like to sign in the system that allows you to ask questions. So it's a Slido app, and I would like to ask you to please fill in a short questionnaire that we've prepared so that we can take a look at some results and so that the speakers can comment. Access to Slido is via a QR code. You can find it on the printed agenda, or you can go to slide.do and enter hashtag data 2023. That's how you access Slido. And now allow me to extend my warm welcome to the Deputy Minister of Health, Mr. Jakub Dvořáček, MEP Ondřej Knotek. Good morning to you. I would also like to welcome President of the Association of Health Insurance Companies, Ladislav Friedrich. Good morning to you. I would also like to welcome the Deputy Director of the VoZP, the General Health Insurance Company, Mr. Petr Čermák. I would also like to welcome Ladislav, Dušek, Director of the Institute of Health Information and Statistics. And I would also like to welcome Ladislav, Švec, Director of the Health Insurance Bureau. I would like to welcome Markéta Benešová, Director of the Health Department of VoZP. And last but not least, Mr. Kolář, Executive Director of the Association of Innovative Pharmaceutical Industry. I do hope that I haven't forgotten anything, and without any further ado, we can start our agenda. I haven't introduced some of the speakers because I'll introduce them when their turn comes to speak. The first to deliver his remarks will be Mr. Petr Čermák from the permanent representation of the Czech Republic to the EU. He is in charge of the public health, eHealth agenda and global health. He'll speak about the European health data space and secondary use of data. Mr. Čermák, the floor is yours. Good morning, ladies and gentlemen. I would like to thank the host, Mr. Tomáš Cikrt, for the introduction, and I'd like to thank you very much for inviting me to this roundtable dedicated to secondary use of data. My name is Petr Čermák, and I work at the permanent representation of the Czech Republic to the EU. So formally, I'm employed by the Ministry of Foreign Affairs, but we practically are very much attached and linked with the Ministry of Health, like a prolonged arm, so to speak. When health legislation is discussed, we are present. So when it comes to the draft regulation, the EHDS, I could be present there. I have prepared a short presentation for this event. I would like to introduce the overall concept and highlight some of the main elements that the system will newly bring about and that will need to be reflected in the healthcare systems, not only in the Czech Republic, but in the other member states as well. And I would also highlight some areas that give rise to discussions and certain controversies, and that may require certain change. So here you can see the fundamental aims of the draft regulation, the EHDS regulation. When adopted, it will come in force and effect in all member states. The aim is to improve access of citizens to their health data in electronic form. The EHDS regulation follows up on the GDPR regulation, complements it, strengthens it. The main aim is to set up a legal framework and support the building of the infrastructure for exchanging health data for both primary and secondary use. In the primary use of data, the regulation aims at setting common standards for the health data, health records that can then be exchanged across the border, and also certification should be, and that will interact. So that can be various software, hardware, etc. And so that's actually chapters 3 and 4, that's the secondary use of data and secondary sharing of data. So that should release the potential of the data economy, which is one of the fundamental objectives. I will be presenting the draft regulation as the EC has presented it. However, it's crystal clear already at this stage that some amendments will be required. So it's not carved in stone, so to speak. Doctors will have access to patient health data. There will be possibility of updates, etc. Patients will also have access. And then through the system that I'll describe later on, the data will be available for research, innovations, etc. And here, just some timeline. So the EC published the draft on the 3rd of May last year. Then the Czech presidency in the second half of the year followed up on the French presidency, during which it was presented. Basically, during the Czech presidency, the first reading was finalized, and a compromise draft was prepared and negotiated. Sweden has now taken over the baton. And now the secondary use of data is to be negotiated, then the Council will prepare its position, that is the individual member states, and the EP also will prepare its position. But as MEP Mr. Knotek is present here, I won't speak on behalf of the European Parliament. But for this draft regulation to be adopted during the term of office, the current term of office, it will need to be finalized in March or April next year. So here, as regards the proposed system. So there are some 4 fundamental pillars of this system, and I will, in a very simplified manner, describe how access should be provided. So basically what we are all interested in is the electronic health data. The EHDS regulation defines minimal categories of health data that should be made accessible through this system to the applicant. And it must be highlighted that the applicant receives the data in anonymized or pseudo-anonymized form. The difference between that is that in anonymized data, 99.9% identification is not possible in the pseudo-anonymized data. A body has a key which makes it possible to identify the person. Then there are data holders. So these are the entities that have the data at their disposal. So it can be healthcare providers, health insurance companies, selected agencies such as the EMA and others. Then the data applicants, that's also another important stakeholder. So these request the data. It can be various research teams, for instance. And then there are the health data access bodies, HDABs. This is the central element of the whole system. Key for the secondary use of data. I'll be using the acronym HDAB in my presentation. So HDAB issues the permit, provides the data. So this is how the procedure can look like, obtaining access to data. And let me reiterate that this is the original proposal of the European Commission, and certainly there will be some amendments, some changes made. An application is submitted, identification of requested data is made on the basis of catalogue. So in the application, the purpose of data processing needs to be described. Permitted purposes are stipulated in the draft regulation. Prohibited purposes are also laid down there. Then the HDAB shall assess the application, whether all the necessary elements have been met, and issues the permit to data. So what data, for what purpose, for how long. HDAB then approaches the data holders from which the applicant requests the data, and they have to provide the data in raw form. HDAB then carries out the anonymization or pseudo-anonymization of data, and through a secure processing environment shall provide the data to the applicant. So, for instance, for a period of 3 years, the applicant will have access to that data and will be able to use the data for the purposes for which access has been requested. Naturally, there are many costs related, administrative and others, that is. The applicant will need to pay some fees for that to the HDAB, so for work related to the anonymization, pseudo-anonymization of data. Part of the fees should also go to the data holders, because they will also need to make some effort to provide the data. There are certain time limits set forth in the draft regulations, so there is some time for assessing at the application, then time limits for providing the data. Penalties are also laid down. So, for instance, if the applicant would use the data for other purpose than the requested one, then there would be a penalty imposed, etc. When a Czech researcher an application to a Czech entity, well, that can be done, but naturally there can also be a cross-border situation. So it can be a Czech applicant that can request data from, say, a Spanish hospital and can make use of the same infrastructure and shall obtain the data in pretty much the same way. I have already described the system, but let me only summarize what novelties the EHDS regulation will bring. So, and again, this is the proposal of the EC, so without any changes. So as proposed, it should bring a new legal framework for access to electronic health data. It will bring about a new infrastructure at national and European level. There will be mandatory involvement for all data holders. Only exemption that's there is for micro enterprises up to 10 employees, so GPs and some very small facilities would be out of the system. All the other data holders shall be obliged to provide the data. Then another novelty is that patients' consent to the provision of health data for secondary use is not required. So this is different. And then another novelty is that standards shall be established for interoperability in data transmission by the data holders, applicants, etc. And here I only wanted to point out some areas that give rise to some discussions or controversies. So, for instance, some member states disagree with the EC's proposed version. So, the first question is the consent of the individual. That should be the legal basis for the data provision. So, whether a patient should provide consent or not. So some stakeholders disagree. They want it to be the same as in GDPR, that consent should be provided. But then others react and say that the draft regulation would not be meaningful because it would only be the status quo. So opt-in or opt-out rather. So that opt-out would be that consent doesn't need to be granted beforehand, but the patient could always opt out. Like that he or she no longer agrees with the use of data. Then what is a matter of discussion is the breadth of the provided categories of data. Some argue that it's too broad, that it will require too much administration and capacity. So there are some voices saying that the list of data should be shortened, or perhaps let's expand. Let's start, say, with 5 categories of data, add some more as time goes by, etc., so that we don't start with everything at the same time. Then another question would be the degree of harmonization of rules. So the harmonization nature is that everything should be enforced in effect in all member states, but there is some flexibility provided by the EC. But when it comes to, for instance, fees or penalties, this raises controversies, because if member states can set the fees and penalties and there are no single standards, then that may be an issue. Then another question is provision of data to entities from third countries outside of the EU, that is. So here the applicant doesn't need to be registered in the EU, so no problem with the idea. But then what some member states require is that reciprocity is ensured. So, when we provide data, then when an EU entity requests data from third countries, they should be provided as well. So we need to discuss how that could be in short. And last but not least, as I've already mentioned, the central element of the whole system, the Health Data Access Body, HDAB, so that shall fulfill a number of roles. The question is whether these roles perhaps should be reduced in a way, because both the primary and secondary use of data may be quite demanding for member states to introduce and maintain. The system that the EC has proposed is based on a Finnish and French system. Finnish colleague who has experience with that usually comments realistically how the expectations could be. And he's saying that part of what the member states will need to invest in the system will be returned through the fees. So it will also, cover part of the operation of the HDAB. Naturally, the fees must be set up in a reasonable manner so that researchers won't be put off by their amount when requesting data. But that's it for me. Thank you very much for your attention.
Thank you very much. So I would like to ask you, as discussions are carried on, who and how or which institution would become HDAB? Would it depend on the decision of national countries, or would it be regulated by FUS? Exactly, the roles definitely could be determined by individual organizations. So it's up to the national countries, member countries, to a certain extent, to great extent. So actually we can ask more questions later on how it's going to be handled in the Czech Republic. And we may continue with discussions on HDAB. And I would like to use the presence of the member of European Parliament, Mr. Knotek. So thank you very much for giving me floor, and thank you very much for invitation. At the beginning, I would like to say that the European Tool for Health Data, in my view, it is a great opportunity, not only for European patients, but also for Czech patients to improve access to innovative medicine, but also for the European self-sufficiency, which is a topic which is discussed today, and it is also important for the economic situation because, of course, it has to be evaluated well. Speaking about European Parliament, we have started to speak about the secondary use of data about 2 years ago when we have established a group of EP members that are in support of innovative therapies in order to improve access to innovative therapy. And in 2.5 years, after consulting with different stakeholders, we have stipulated a list of recommendations. And one of the recommendations is to efficiently process data in RWE mode, and for that it is necessary to establish HDS, a tool that allows secondary use of health data. So in the European Parliament, part of the EP members really understand the added value, so they are in favor of the secondary use of data. And nowadays we are going to discuss it in two committees. One is the ENVI, EP Public Health and Food Safety, and the other one is for the human rights. So ENVI committee discusses the added value for patients primarily and is happy with assurance that data are sufficiently protected. The LIBE Committee on Civil Liberties, Justice and Home Affairs, unfortunately, just has a certain measures or timeline between the European elections, and it will be a pity that we will just have some opportunists that will try to label secondary use of data as a tool of losing the freedom or a tool how to control humankind. It will be a pity if we lose the added value, and that's why I propose to focus not only on the content of the regulation as such, but also about the credibility of the tool, because I think the tool is necessary for appropriate use of the secondary data use. We can just submit the amendment proposals, and it is possible that in July or in September, those two committees will just be clear about the position, and it will be subsequently discussed in the European Parliament. And I think it is possible to make it happen by the end of March or beginning of April 24 to approve the entire regulation. So it will be heard and discussed also by the European Commission, by the individual member states and the Parliament. Speaking about the content, maybe I will surprise you a little bit, but the discussion of the European Parliament is not that detailed. Probably it is not the appropriate body. So what is happening usually 2 to 3 milestones or 2 to 3 areas of topics are being created, and one of the area is the secondary data use in the health sector and the role of patients. So in fact the Commission proposes patient is part of it and should decide, but there is a contra proposal stating that patients have to decide about everything with respect to the secondary data, which is the opt-in mode, and once you have to approve all the cookies. But I think in this aspect it is more important. So what we try to do, we try to promote pragmatic and also technical feasible option. That means opt-out when the secondary data would represent an integral part for patients to be part of it. And in fact, we don't want to move the topic to some opportunistic level, so the citizens should be able to choose to opt out. So that's about it, which is the main topic. Nowadays it is in this topic, and I think it is a balance between the human rights and those who promote innovative therapy for people, and this is going to be one of the main arguments. Thank you very much. So I would like to double-check my understanding. Speaking about opt-in regime, then the patient would have to actively express the will, which would kill the entire system, in my view. Or are there any ways how to rescue everything? Exactly. For the secondary use of data, opt-in is absolutely not appropriate, practical. I don't have any feasibility studies to support this thesis, but I'm quite convinced that the volunteers wishing to participate in the systems would realize, and the added value is an aggregation of big data, and the opt-in is really not practical or feasible for the secondary data use, and those who promote it would like to damage the entire system. So opt-out is a political compromise, which of course may be expressed in several options, variances. So while talking about opt-in and opt-out, we are discussing several terms and conditions, of course. So opt-in is definitely not the right choice. Speaking about opt-out, does it mean that the health insurance companies would have to delist or actively declaring patients they would like to opt out, so they will not allow those patients to have access in the secondary data? For instance, we may have the information from hospital A, with the exception of 10 patients that would choose opt out. Yes, exactly. This could be technologically managed. Thank you very much. I think it's really important what you have said, how we are going to communicate about the entire secondary data use system, because the abuse may be huge and may kill the entire system. Yeah, it is really necessary to maintain the credibility of the system. Thank you very much, Mr. Dvořáček, Ministry of Health, would have to somehow transpose the European ideas into Czech practice, and should we wait for the approval or determining the main strategy? Do you already know which organization should become the HDAB? I think we still have enough time to determine that. We still have time to determine HDAB. What is substantial? We should boost an energy into it once we know it makes sense. And it would make sense once we have majority of patients in. So I'm in favor of my colleague's statement. Provided we would choose to opt out, the project would be killed. So we would have to terminate the entire system. We don't have much time, so the discussions would have to be organized soon. In my view, there are several parameters that are really important for us. We are talking about the fact that the entire secondary data use should strengthen roles of key stakeholders. I'm not talking about the industry only. I'm talking also about the patient organization, academic segment, and so on. Because as it is designed now, there are certain thresholds for those bodies to enter the system. So I think the academic sector would have to play more attractive role in partnership with the industry, and also they should be able to work with the data independently, and they should be able to submit data on their own. I think the role should or can be substantially strengthened, but also the risk moments are not sufficiently clarified yet. I guess they are described in the follow-up document, but I guess we will discuss it later on. We can discuss it later, of course, but if you wish to express it now, you can just emphasize a few points. I'm convinced that the entire strategy should support primarily the European industry, so the discussion who should be the partner should be carried out, and we should address companies headquartered in Europe, and we can then strengthen their activity within the EU, which is the key to success in my view, and of course communicating with the entities from third world countries. Yes, of course we can do so, but we cannot just design the communication channel only for the USA. No, I think we should strengthen the European pharmaceutical industry, or the industry which is already existing within the EU, and help them to develop further. What Petr Čermák had also suggested, funding, of course, this is a great challenge for all member countries, and it is not real to think that the system will be self-funded. So, in fact, the entire system will represent quite substantial burden, not in exactly appropriate period of time. So, I think great discussion would have to follow to what extent the system is self-sufficient, how it's going to be funded, and how much would have to be co-financed, and so on. What is also important are the bodies that are caring about public health insurance in individual member states. So in the Czech Republic, we are talking about health insurance companies and how they will be able to verify the data submitted by patient organizations, specialized associations, and so on. And I think this will substantially strengthen the role of health insurance companies. And I also think it's ideal time to trigger the time when the voice of health insurance companies would be strengthened and heard. And in fact, we should be able to assess those technologies in more realistic way than today. Thank you very much. Yes, so in fact, this is an opening to the health insurance company's presentation, in fact, but let's stay a little bit for the European space. So do you think that the EHDS will benefit health insurance companies? Well, in my view, I see a couple of unclear elements. So devil is hidden in detail, which is true for this system. So at a general level, I think it is an interesting project, quite ambitious, provided it expects that the borders of individual member states will be opened. In fact, Europe exceeds the original idea that social and health insurance systems will be excluded from the integration, and their success rate and efficiency would be evaluated, and only then, once this task is done, it will be united. So that's first element we will see. Speaking about Czech specifics, I would like to highlight a couple of points. So in fact, all strong secondary data that are currently available come primarily from the reimbursement of the healthcare. So the system of the healthcare is a live system, works with several attributes, several levels of details. So originally we had almost 100% health performance. Currently we are using the DRG system, or we can apply the flat charge for bed days and occupancy, the bed occupancy rates and so on. So this is changed based on the mechanism, which is currently not respecting at all general use of secondary health data, because in fact it is designed for the primarily design, which means to reimburse provided health care. So second comment. In order to allow health insurance companies to be able to use the health insurance data for 10 million of insured person in the Czech Republic, or hundreds of European citizens, the health insurance companies would have to be flexible, because the queries don't have to be primitive based on the elaboration of any system. It has to be iterative. So in order to elaborate on the potential added value, I need to connect to certain pool of data and be able to modify queries up to the moment when I'm happy with the result. And I think that does not correspond with the general accessibility. So I would be in favor of specifically allocated access for the payers, because without that it is not possible. The third comment is that a certain view on a duty to either enter the data into the system or not to enter into the system should also consider the fact whether this performance are paid from the solidarity health insurance system, and then as a patient I am obliged to accept certain limits because I would benefit from the system. Nevertheless, provided those health insurance health performance is privately paid by the patient, then I am not convinced whether we should force patients to share this data. Why to share this data? Then they should also report when they would buy new shoes, for instance. So everything is interrelated. So I would say that the view on the solidarity system that in most European countries make the provided healthcare accessible may be more extensive compared to privately provided healthcare. That's just a comment at the beginning. Thank you very much. Then I would like to highlight that we would have a part of today when we would invite Professor Dušek, and in fact it will elaborate on the Czech specifics. So we will come back to it later on, but I would stay with the European level for time being, and I would like to invite the representatives of health insurance companies. Do you think that the European regulation would benefit health insurance companies?
Good morning. I must say that the draft HDS regulation is an entirely new thing to me. And as presented by Mr. Čermák, how I see it is that I perceive huge risks in there. Perhaps representatives from the Institute of Health and Information and Statistics may oppose, but we'll need to implement an entirely new eHealth, so new standards that will allow exchange of data. So that will be in the purely basal form, and we haven't really mastered it even at the level of the Czech Republic. What is of interest in it is that the patient can get access to his or her data. I see this as a big handicap of the current system that we have, and I very much agree with the president of the Association of Healthcare Companies in that respect, that patients should get access to their health records administered by the doctors. There are some intersections at this stage, but I, as a patient, definitely want to see the documentation held by the doctor and not just what has been reported to a health insurance company. So, the health records kept by the doctor should be, the primary data. And then when it comes to exchanging data at EU level, I understand that when it comes to secondary data, and I do apologize if I'm imprecise, that when we speak about medicinal products, I think that it's a good possibility to see, for instance, what the consumption of medicinal products is, how efficient, for instance, it is, etc. So, things like that could help the system. And what benefit for health insurance companies there can be, I'm thinking about it. I'm not sure whether and to what extent, for me as a health insurance company, as regards some trends, what it can bring at this stage, I'm not sure really. So perhaps we may get to that in the discussion, so some impetuses may be on it. And Mrs. Benešová, please. Well, I think that the negative aspects have already been raised. I believe that for health insurance companies, the benefit could be that the data or for instance, the trials based on the obtained data could then be beneficial. And what is also of interest is that it should be standardized data, because we get various applications without not much specification, huge scope. We then strive to give some framework to it, like what we can provide, what we can't. And I believe that this would establish order when it comes to applicants for data. Thank you very much. And now let me pass the floor to the Executive Director of the Association of the Innovative Pharmaceutical Industry, Mr. Kolář, to say something about how the EHDS regulation can be beneficial for the Czech Republic. Thank you very much, and thank you very much for this first round. It's interesting to see how opinions differ among you. I have put our position document in your background materials. It's some 7 pages, and because we have provided support to this event, we have dared to put our position document in the folders. We see a huge potential in the draft HDS regulation. We also see certain issues, and I'll get to that in a short while, but I must say that I believe that this legislative path is a huge potential for Europe as such, and specifically for the Czech Republic, because it will bring about a possibility of standardization, interoperability of systems, and at the same time it can boost what the Deputy Minister Dvořáček has mentioned, some improvements when it comes to innovative therapies. There are some question marks, but it's only a matter of clarification and interpretation of the individual parts. So let me, for instance, touch upon the purpose of secondary data use. So, for instance, the draft regulation speaks about the marketing activities and advertising activities. So the question is what that is. The Deputy Minister has hinted to it that the data and source materials that will be submitted when new innovative medicinal products are presented and the East Institute for Drug Control and health insurance companies, that the secondary data could be used for that purpose as well. And the question is, will that be possible or not? And so that's one issue. And then another thing is, and then this is an interpretation issue, and this is the business secret and so data privacy and ownership. That's the there is some uncertainty from the current wording for pharmaceutical industry, that is. And let me also touch upon the opt-in, opt-out principle. I do agree with what has been said, that if the system is based on opt-in, it completely loses its potential that it would otherwise have. And FBM saying that opt-out is not really necessary because GDPR already regulates this area. But if opt-out is a compromise, then fair enough. Because we already have experience from the e-prescriptions that this system can work. All patients actually do participate in the e-prescription system. So that's some of the issues, and I believe that EHDS should really serve the purpose that Europe stays attractive for innovations and boost its potential. I would once again like to thank the Czech Ministry of Health for being active in this respect, and that it's realistic that before the current term of office ends, it will be negotiated and adopted. Thank you very much, and let me ask the audience to be involved in our interaction. So please use the QR code or go to Slido, so slide.do, and enter hashtag data 2023. But perhaps the QR code is an easier way to get to Slido. Feel free to ask questions. Some have already arrived, and you can also vote. We have some 40 people following us online. Not everybody has been involved in the voting. We'd be very happy if you complete the questionnaire so that we have some results. Professor Dušek and Švec will deliver their presentation too, but let me ask you also with respect to what's going on at European level. If, for instance, at European level, there would be the opt-in, then that would really demolish everything that has been built to date. What do you think, Professor? I won't really comment what's going on. I'm not competent in that respect to make any legal or political statements. But what I understand and what my responsibility is, that, when we should build the health data system, what's going on at European level can't really impact our Czech efforts. It can only help it. So that's my first remark. And then secondary use of data in the Czech Republic is in full swing. It's just not finalized because of COVID. We need to catch up on certain gaps. So there, yes, are some deaths out there, but secondary data, that's how I see it from my lay world. So it's already stipulated in legislation and it's ongoing. So various entities ask for data. They are not ostracized, classified in groups. So, for instance, members of the academia are not really separated from somebody else, from medical society, etc. So all is treated equally. And then thirdly, as for the debate about the opt-in, opt-out, I don't really grasp the point, I'm afraid, because if I start to use some data, that is secondary use of data, so a certain system adopted with the GDPR can't allow an indirect identification of an individual, so that's already adopted legislation, isn't it? And you can do secondary processing of various data. So the raw data, you can for instance, have instead of specific hospitalization data for, say, August and not the exact dates, things like that can be done. So then it doesn't make sense to debate opt-in, opt-out. I can't even envisage a serious debate, opt-in or opt-out. Can anybody really seriously debate that a citizen of the Czech Republic fills in a form somewhere, and based on this form, we won't be able to, for instance, enter this case in, say, breast cancer statistics or register. So, for instance, a lady doesn't want to be included in breast cancer statistics, even though she has breast cancer. That's nonsensical. And then, whenever data should be provided, being part of any clinical trial, in a retrospective, observational clinical trial, and it would be personal data or other highly specific data, or genomic data, for instance. These can't be anonymized, etc. So then these would be projects where patient would be at stake like this. Then there has to be opt-in in those cases. So I would understand it this way, but otherwise you can't, for instance, erase a citizen from an epidemiology statistics, can you? MEP Knotek would like to add something to the debate. Please use the microphone. Probably it's not going to be that easy. No, but is the answer. So what you are hinting to is completely correct. I completely agree. State, government, responsible for health naturally needs to have statistics in order for its purposes. How I see the practical part of the debate about opt-in and opt-out is as follows. Citizens who do not want to, for instance, wouldn't need to provide data to, for instance, private entities. But you have mentioned something based on common sense. And now it's very difficult to say, and it's really difficult to say because I work for the European Parliament. I'm an MEP, but I must say that the discussion often is at the European Parliament very political. And my homework, and this is how I approach it, is not to put at risk, because of some ideology, this work aimed at finding the right solution. And because it's only a year to go for the new European Parliament elections, indeed, there are some opportunistic debates. Attention is being drawn to this theme. Some people are saying, well, we're going to protect you, you're not going to lose your data, etc. We indeed don't have space here for real debate. So we must get rid of this ideological element in the discussions. And I can only assure you that nobody has ambitions to indeed take away precise data from institutions that do require those precise data. But that was just, the line in the European Parliament. Thank you very much for this explanation. And Mr. Švec would also like to comment. Thank you very much for the floor. Let me only add to what the previous speakers have said. I can't really imagine application of the opt-in system. It would have an impact on our internal structures, reporting of data, etc. I do hope and do believe that nobody will seriously come with this proposal and will not strive to push it through. Thank you very much for this comment, Mr. Švec. So that was Mr. Švec from the Health Insurance Bureau. And then we have a question from the audience. How will, in the context of EHDS, the interoperability gaps that are out there? Well, there is the DrSc system and insufficiencies as regards HL7. Would anybody like to take up that question? So, Professor, would you like to take that question? Well, I definitely don't want to be too proactive, but I must say that we have Act number 325 that basically stipulates that guidelines and decrees are issued. Well, this piece of legislation needs to be implemented, and when I take the floor later on, I'll speak about that. We are actually able to share some 30% of data, not more. So that's the reality in the Czech Republic. We need to go down on earth. Well, we are basically collecting here bananas with, the that are not fully available with the banana skin, that is. But anyway, I must say that all those who work with data should be in compliance with the definition of data as actually issued by the individual European bodies of the ECs. The regulation will address not only the primary use of data, the provision of the data by the providers, and then the question of secondary use is also addressed, and we're here to discuss that part. But that is only a certain component of the AGS. Thank you very much. And now let's move on to our second topic, and that's the good practice of secondary use of data. And I would like to hand over to Professor Martin Haluzík, who will now take the floor and have his presentation.
Ladies and gentlemen, I would like to welcome you at IKEM, and I would like to thank you very much for having the opportunity to take the auspices under this very interesting discussion. So I would like to base my paper on something more specific. Nevertheless, it may be used as an example what data can be retrieved, obtained from our systems. I would like to share with you our HOBIT-FS the clinical trials, which covers patients that are obese and with the fibrillation. In the Czech Republic, there is high occurrence of obesity, which is associated with a lot of metabolic or cardiovascular complications. In the Czech Republic, we have only 35% of inhabitants with a normal BMI, and one of the most important thing is the atrium fibrillation, which may lead to failure of heart, risk of cardiovascular, and it is all associated with obesity, which represents one of the most important risk factors. We know that slimming down decreases this risk and also decreases the risk of reoccurrence of the atrial fibrillation. The ablation is in fact one of the most important methods to reduce this risk. This treatment, of course, don't have to be efficient unless we help the patients to reduce other risk factors, and this is exactly the core of our clinical trials. We just tried to show once we decrease the weight of patients by 10%, we also decrease the probability that once the ablation is carried out in those patients, they will also reduce the fibrillation. In ideal world, the fibrillation would never occur again. So we try to highlight that by reducing the weight by 10%, at least, we will just have a great impact. I just wanted to highlight that it's a randomized clinical trial, so with an intervention branch that tries to reduce the weight by 10%, then a non-intervention branch, which in fact shows the standard clinical practice. So the patient takes the ablation, and it is all about the decreasing the risk factors, and we have monitored the patients for the period of 18 months, and we monitor those patients not only in standard clinical method, but we provided Apple Watch to those patients that monitor physical activities, heartbeats, and so on. And by the way, it is able to identify the atrium fibrillation. So BMI 37 that are subject to atrium fibrillations were included in the clinical trials. It is very complex intervention within the HOBIT-FS clinical trials. We all professionals together with the nutrition therapist in fact monitor the patients with the help of Apple Watch. Apple Watch generates a very interesting secondary data set. And also, who of you uses Apple Watch, by the way? Yes, yeah, I'm one of those who proudly declare I'm using Apple Watch compared to my wife, who really did not care about the Apple Watch. She was able to have it only for 1 minute. So I think that for men, ambitious men or ambitious women, it is possible to use Apple Watch. And we have observed that it really works well with our portfolio of patients. What is really interesting is that we have really strong IT department at IKEM, and we were able to develop this application for Apple iPhone, and the patients can monitor their health condition. Why it is appropriate? Because it transfers the data to IKEM system. So once the patient comes for checkout, then we see the patient's data in our system. In addition to traditional data, we are able to communicate with the patient. We are able to motivate the patient and so on. We have IKEM online fit application monitoring physical activities, and We also show the results of the medical exams to our patients. They can check their own data and so on. So it's all in one concept, both for patients and the physicians. So patients can share their results with other healthcare professionals or with anybody they would like to. So it is a huge data set, and I can see it from the position of patients, but of course the data generated in Apple Watch represent high value for us. We have included 160 patients in the randomized studies, 80 passive, 80 active, and I just wanted to show you the appropriate data here. So those patients come in 3-month period for the first medical check, 12 and 18 months check, and we can see that the active branch started with a little bit increased glycemia, and we can see the data with the decreased weight. We have identified about 30% of patients that were not aware of the diabetes or increased glycemia, and on empty stomach, so fasting glycemia, and all parameters closely related with the progress of the clinical trials. We can see the decreased weight from about 120 to or 110 to 100 kg. It was a randomized clinical trial, so some patients would prefer to be randomized in passive arm, while they were included in the active arm, and that's the trouble of randomization. Of course, we try to educate everybody about the slimming process. We can see the Apple Watch results. We can see increased number of steps, burned calories, active minutes, and we see the image from our information system. We can see the decreased, reduced weight here. We can see the patients that just went to bariatric surgery, and they just slimmed down by 30 kilograms, which is hard to achieve by conservative treatment. We can also see that the patient's physical activities and so on. The secondary data could be used to optimize treatment of those patients, of course, to optimize recommended physical activities according to heartbeat. The Apple Watch is used for EEG weekly monitoring, and in fact, the patients are compared with the active arm. Then about 40% of patients had completed the clinical trials now, and the rest is still going on. Nevertheless, I believe that we will successfully complete it. I already suggested that we have identified diagnosed diabetes in 30% of the patients. We have also focused on the sleep apnea. So it was second tier obesity, 36. So 40% of the patients suffered sleep apnea, and in fact we have referred them to the sleep laboratory, and their treatment started. We were also interested in hormone, and we have identified deficit of testosterone in 30% of men, and we don't have complete data yet. We are working on it. So I would like to thank very much to IKEM for the HOBIT-FS. Apple company had grant us a grant for the Apple Watch and iPhones and so on. Without them, we won't be able to conduct that clinical trial. So I just wanted to show you my colleagues, and I would like to thank them very much for their effort. And I would like to thank you for your attention. Thank you very much. So me obese with Android system, I would have a lot of questions, but it would require more time somewhere else. So you are working for IKEM with strong IT department. So in fact, you can manage everything on your own. But despite that, what secondary data of health insurance companies would be useful for you? I'm the president of Czech Obesitology Association, so I would really be interested to get data on the obesity status in the Czech Republic. So the BMI cannot be retrieved easily from the data. So if I may, I would like to suggest that those data should be made available, because we are sharing with you estimates only, and it will really help us a lot if we can get actual current data, matching it with the specific patients and suggesting appropriate physical activities for them. And of course, we would like to be cost effective, and I believe that we will just succeed in some period of time, because unless we start treating obesity, we will face a huge challenge and we won't be able to fund the system anymore. So thank you very much. Now I would like to invite the second good example of the secondary data use. I would like to use the head of the strategy department of the health insurance company OZP of bank employees, insurance companies and construction industry. So allow me to introduce sorry, I would like to ask you to take the mic a little bit.
Allow me to present to you our portal that OZP has. May I ask for the presentation? Oh, I need to click on the slide myself. Thank you very much. So it's called Vitakarta. It is an app that currently has some 50 functionalities, and it is something that allows OZP policyholders to deal with all sorts of situations in the online space. I will speak about its potential in secondary use data. But before I move to that, OZP is a health insurance company with 770,000 policyholders. We were practically the first health insurance company who has the system of credits or benefits tied to preventive programs. And we have offered to our policyholders the Vitakarta app that allows our policy holders to access their data online. We have had it for some 10 years. It allows us to build more advanced functionalities for exciting medical applications. So Vitakarta already has some advanced functions. So for instance, it can evaluate the ECG from smartwatch. The policyholders can create their health profile. It also gives you alerts regarding prevention and gives policyholders possibility to evaluate the quality of provided care and remunerate doctors for providing high quality of care. It also allows for identification of chronic conditions and very soon it will allow to share lab results, sharing these with other doctors who may need those data. I would like to show you two examples of what Vitakarta allows. One is the medicinal products drug interactions, that is. So it can be something that is a watchdog, so undesirable drug combinations are alerted to. So here you have a screenshot of for instance, these drug interactions that are undesirable. You can click on the individual drugs to see the details. So each drug is tied to the information from the State Institute, from Drug Control, and so it's the patient information leaflet that there is direct access to, plus there is also access to the OTC drugs. You can, for instance, erase a drug if you no longer want to have it in this interaction chart. And here you can see the overview of all the drug interactions of all the drugs that you have in that comparison. So you can erase those that, for instance, you no longer take, etc. And it alerts you to, for instance, some issues that may arise, for instance, that you shouldn't eat some herbs, etc. Then there are various degrees of interactions. Then if a serious interaction is established, identified, then we send push notification and we point out this fact. We only present it as information, so it's a statement informative in nature, and we recommend the policyholder to consult his or her doctor who has prescribed a given drug, or discuss it with a pharmacist. We also offer advisory services. We point out to policyholders that we only have information about drugs that have been dispensed to the policyholders, not what has actually been used by the policyholder. So in 2022, more than 52,000 notifications were sent, and some 500 people approached our drug advisory service that we offer. As for statistics of the aggregated data, so we look at the occurrence of interactions broken down by 5 points of the ATC classification. Now, let me move to another topic, and that is the chronic conditions. We have a classification mechanism that actually breaks the policyholders down into various chronic conditions groups. We have some 35 of them at this stage. When a chronic condition is identified, we again send a push notification to the client to alert him or her to this. So probably you suffer from this or that chronic disease. The policy holder either confirms or rejects this information. So like yes or no, do you suffer from this chronic disease? And then the policy holder may add further information in the health profile. These individually entered data are also aggregated. So when the policyholder confirms the chronic condition, he or she is sent very simple information. We don't want to replace the role of health service providers, but we send straightforward information about what this chronic condition means. So, for instance, hypertension here. And if the policy holder shows interest, we can send some further general information. The algorithm makes use of machine learning, artificial intelligence, AI, so it's based on constant evaluation, and it indeed does help us if the policyholder confirms the identified chronic condition. So it's not about, for instance, a doctor her reporting a certain diagnosis or treatment. So this whole identification is very complex. Many other interlinkages come in play, including gender and time, over which we've been monitoring, reporting of given data, etc. Even though one other thing is not really related to our Vitakarta app, the database of these identified chronic conditions are used in our further project, and this is the treatment plans that have elements of disease management program. This database is then provided to GPs who are actually involved in that system. And here we monitor and also compensate the care provided to patients. Very briefly, for reasons of time constraints, let me show you the following. So our policyholders in the Vitakarta app have not only an overview of reported treatments, but OZP went even further. Already in 2016, we allowed our policyholders a possibility to check the treatments, so they can report, for instance, if something is established, that there is a discrepancy is established. So this is an important piece of information for OZP. It provides us with vital information regarding quality of provided care. And we have this data plus the patient has this very straightforward, easy to navigate information about the treatments and the cost of them. So here, when it comes, for instance, to drugs, so here you can, for instance, see the breakdown of the fees. So this is the fee to the pharmacy for the prescription drug, and so on and so forth. So very detailed. We can take a look now at the number of users of Vitakarta. So our OZP insurance company has 770,000 policyholders, of whom 73% use the Vitakarta app, and they have granted us consent to process the data that Vitakarta monitors. And when we look at the number of unique access, so more than 60% of those who are registered actually actively use the Vitakarta app. Per month, roughly 100,000 clients access the Vitakarta app, and our managing director, Kolář, says that, well, let's imagine that these 100,000 clients would be coming to our branches. We wouldn't be able to serve them. So it's vital that they have access to this information in the online space. We also do things that policyholders enjoy. So some feedback, positive feedback that we've got from our clients. And here, when we made it possible to provide this evaluation of the Apple Watch ECG. So our client here is saying, hats off, I would never believe that I would ever say this, but I'm proud of having my entrance with your company. I do hope that this digitization trend will continue. So we indeed strive to provide maximum added value to our clients, plus we also fulfill an information and education role. Thank you very much for your attention.
I only would like to ask technicians not to switch off our mic because I would like to speed up everything. Thank you very much for your contribution. Time is running, so I would like to invite Professor Dušek to share with us his paper. Hello, thank you very much for the invitation, and I have to say that Mr. Zickert had alerted me yesterday that I have to be short, so I have taken with me only 70 slides, so it is not possible to beat the previous paper. I have to answer two questions. My view on the added value is the secondary use of data, and my personal attitude to the situation in the Czech Republic. I will try to share with you two examples where is the highest added value in my view. It's slightly different from the presented situation, since we will manage to transfer the data from the first to secondary data use. So at the central level, in my view, data from several multiple resources will allow us to evaluate strengths and weaknesses, which will not be possible using only single data sources. So we try to focus on the oncologic gynecology, which is really paid well. I'm not a physician, not the oncologist and gynecologist, and please focus on the yellow data only. The data will allow us to fully evaluate the epidemiological burden. So 100% overview on the situation of female patients in the Czech Republic. We are able to monitor the long-term development. The primary incidence is not growing. However, despite the longer lifespan, the prevalence is increasing. And in order to be able to evaluate it, we need to know the condition of the patients plus the condition of the illness. So speaking about the breast cancer, you saw the data here, 100% versus 80%. Of course, we also monitor on accessibility of care. You can see the oncological, gynecological surgery is not bad. In the Czech Republic, nevertheless, 25% of those tumors are subject to surgery outside of the specialized centers. So patients are not referred for a primary surgery to those centers. Mammar surgeons told me that this is not a good picture. Also compared to Europe, our mammar surgery, breast surgery is decentralized. Then we have also developed a panel of, let's say, 40 to 50 indicators that, in fact, develop a list of best of Europe. I guess you are all aware with that, and this benchmarking of performance, it is done based on this list. So all the centers can see the performance, efficiency, and the life expectancy and so on of the survival. And we also have centralized reimbursement data, and it is quite good picture. Nevertheless, there are a lot of question marks that need to follow up the situation, and we also centralize reimbursement of the care provided in centers. I'm personally pleased with this development. We also monitor the early detection, and we are talking about early detection, primary detection. We see the lung carcinoma, but you see the red and orange colors, which highlights later diagnosed tumors with low survival expectancy. And well, I have covered this paper in 3 minutes, which would require a whole day conference. In fact, it is not in fact, making the single source data presentation. No, we have used multiple providers' data provided by many data resources, specialized centers, reimbursement centers, predictions. We are working with the health insurance companies, which is quite subjective, very precious, valuable secondary data. My second example is from totally different area, complex data allowing to predict required sources for certain segment of care. I have taken an example of the care provided in centers. I remember when I was young, we have predicted the required amount to be 1 million crown, and we were shocked then. Nowadays, it cost billions of crowns. Well, I have to say that secondary data are already shared in the Czech Republic, even though the system is not yet ideal. We centralize the data provided by SUCO, provided by the health insurance companies on the drug consumptions, and information about how they manage to push down the prices of the unit price of the drug. Without this system, without being able to optimize it for the future, we are talking about a huge amount of money. Again, I don't think you need some explanation. You need long-term population trends. We have almost 1% data. This is example of rheumatology. Again, multiple source data, Purkyně Association, Rheumatologic Association provided data, and so on. I'm looking forward to get complete data for 2022 for rheumatology. I guess it has been done yesterday, so it is great. You have started using a new information system, so I'm really looking forward to get your input for the future. On the rheumatology, you see that in 22 data was collected after COVID, so it is difficult to predict the future data development, then development of unit prices in the treatment provided in centers. So those are long-term models done recently in 2019. Then during the COVID, we have interrupted our activities. For 2022, we have predicted 24 billion. Probably it will be almost at the amount of 27 billion. So we are able to predict it for years to come, and we are able to adjust budget for it. So I just wanted to share with you on a subjective view on the value of secondary data, and I would say that in both examples it will be great to be able to share data across Europe. I don't want to touch data of anybody. The data are already anonymized, and the specific patient name and so on will never be shared. We got a few patients in the Czech Republic for certain diagnosis, so it's hard to predict the development based on few patients only. If we get data from the entire Europe, it will really help us to boost the calculation engine. So I think we are mixing up the two notions, data sharing and data accessibility, but it's not like that. I can just highlight it again, and it was not about opening the data, definitely not sharing personal data. Once we open the data, then we need to be able to open the data at the primary level of rows and lines, individual lines. I don't want to read out this slide. This will be published by or submitted to the Ministry of Health. Hopefully it will be approved then. It is a brand new system for our National Health Information System. Hopefully we are striving for the position of being best in Europe. And we are not, in fact, inventing anything new, but we are not lagging behind. We are at the front line together with Denmark or Sweden, for instance. For instance, if I'm opening individual lines, for instance, word giving, I have to be really careful. We need to check the data carefully. We have to exclude data that cannot lead to identification of the patient. For instance, if you hack data, you distort it a little bit, and you won't share the exact date of hospitalization and so on, then it will allow us to do it. Don't mix secondary use of data with the open data regime mode. Totally different thing, also governed by totally different legislation. And let's open, but first of all, we need to be able to collect those data, because without standardization of health records, we won't give complete data, and it will lead to big troubles. If, for instance, one hospital won't code certain data, then, for instance, if they just use a description, it's raining outside, or the patient is subject to this or that surgery, then such information is worth of nothing. Then, of course, data won't be submitted to the health insurance company, and the health insurance company will get the true picture, and then I will also not get the information, and I would be crying, and then I would declare to the Europe that we are not collecting data with the clinical stage of the tumor. Then it will be really giving a bad picture about us, and I would say that this motivation to use standardized data, it will be good. I would like to be retired, in fact, knowing that everything is running smoothly in the Czech Republic. So if my colleague will enter data here in IKEM, will just enter it forever, always. It is true that data would have to be entered by qualified staff, and then it will be transferred. In fact, I'm proud Czech citizen, but what is going on in the Czech Republic? Hospitals are in fact using typewriters sometimes, and if in fact they would like to report it to the Institute of Health Information and Statistics, what they do, they are retyping actually data generated in typewriter to a system, which is not a correct approach. And I don't want to bother you with the information. What is missing in parametric coding? Just randomly listed data. We need to be able to stipulate a true parametric driven system, and without that we cannot really generate useful data. Thank you very much. You have already suggested, and we already discussed it about 4 hours, and our discussion will be published in our newspaper. Nevertheless, I would like to ask 2 questions. How should I proceed if I wish to retrieve data from the National Health Information System about care provided in these centers? My current experience with requesting data from the Health Institute of Health Information and Statistics, my experience is not excellent. Then second question, when the decree shall be adopted and approved? Microphone, please. So I can confirm that during COVID pandemic, we were lagging behind. We were not able to do everything in time. Currently, you should fill in the questionnaire posted on the website, and you should get the answer latest by 3 weeks. If you don't get the answer in time, please contact me, and we'll try to improve the situation. Post-COVID period after 2022, I think we are improving our performance. Then data sets, it is not governed by a degree and will not be governed by a degree. It is only governed by the Act 372. The open data set, once prepared, don't have to be stipulated by any special decree, and once approved by professional association, then it can be handled. I can promise that in 1 week or 2 weeks, we will get a robust data sets from the National Reproductive Health in the Czech Gynecologic Association and so on. Hopefully I've managed to answer, and I would like to apologize once more, provided your request ended up in the COVID queue. I apologize. Okay, thank you very much. I would like to ask a question from our participants. What are the relevant reasons for sharing and using health data for secondary use? 26 respondents had responded, and they all agreed that science and R&D and innovation is the most important one. Then 24 responded the decision-making processes of legislators and regulators. I can talk more about it, but we don't have much time now. And then the efficiency evaluation of money paid. Then we asked about the experience with Act 106. 18 respondents had responded, and most of them got the answer, but most of the respondents answered partially. Answered. Now I would like to invite Dr. Švec, Director of the HIB.
Thank you very much for the floor, and thank you very much for the invitation to this roundtable. I regard the secondary use of data as a vital topic also with regard to some conceptual changes in the Czech healthcare systems envisaged. Allow me to quote the Book of Books. At the beginning was the Word. This is what the Bible says, but it's some big truth. Only when we can describe a certain fact, measure it, and processes can we have a stance towards it or use it for a certain purpose. And in my opinion, this is the situation of data processing and data as such. The existence of data in whatever amount of whatever resources in itself brings no information whatsoever. To get from data to the information, we need a team of people who can navigate in that data, can prioritize and create information on the basis of data. Then thinking about secondary use of data in public administration, this step 2 doesn't suffice. So somebody creating appropriate information based on data, we should always require that data processing leads to further use, to motivated decision-making and actual implementation. in the real world. Speaking about data, it's not just who gets access to the data, who and how can process them, but who has the motivation and competence based on the data or established information take specific steps. And here I think we have a much bigger problem in the Czech Republic. So it's not the processing as such, but that. It has been mentioned a couple of times that secondary use of data does occur already. Yes, that's true at various levels. Even the Health Insurance Bureau operates a fairly robust and functional system of measuring, evaluating performance, efficiency, etc. We provide reference statistics to policyholders, and we develop those areas. However, just like the professor, let me also look inwards and be frank and say that in terms of the overall use of the potential provided by data in healthcare, we are at the very outset. Only part of these possibilities offered by data is used, and there is a huge amount of work still ahead of us. The topic of today's roundtable should be availability of data for secondary use, description of the current system, of the status quo in the Czech Republic. That is, I would like to say, and I'm following up on what has already been mentioned here, is that the Czech Republic is in a unique, specific position. So besides the data administrators, providers of healthcare, health insurance companies, etc., there is the NZIS, the National Health Information System. This is the Central Data Repository. And so NZIS is usually approached not the individual agenda administrators. Well, this is understandable because it's easier to request data from this central repository rather than approaching the individual institutions. The professor has already touched upon it, and I presume that this is how it works, is that when an applicant requests the data, potential conflict of the public interest should be taken into consideration, and that naturally, the Institute of Health Information Statistics is also envisaged and there. So when we take a look at potential approaches to this. Either we can provide everything to everybody or nothing to nobody. So that's the two extremes. If you provide everything to everybody, you risk, for instance, the ability to verify data, more harm than benefit can be achieved. So that would be wrong. But the other extreme would also be wrong. So nothing would be provided to no one. So then the data would not be used, or discretion or prioritization may be applied. So what you provide to whom, etc. And the truth, I believe, and as always is the case, lies somewhere in between. So that's the ideal approach. That would be a compromise. So for the Czech Republic, this ideal solution can derive inspiration from what was mentioned at the beginning here, and that would be the draft EHDS regulation. I don't want to repeat what the EHDS says, but basically what it stipulates is that there should be an arbiter assessing the application. So the question is who that will be in the Czech Republic. It shouldn't be the typical data processor, etc. The HDS also tell us other things and contains other parameters that we should make use of in the Czech environment. So whether we agree on our national principles based on the European legislation, however, in any case, if the public purpose is well specified, I don't see any reason why data should not be provided to the applicant if there is the corresponding degree of anonymization or pseudo-anonymization. So again, this is something foreseen by the EHDS, and what I really like about the EHDS, and well, I must say that there is this obligation of the entity processing the information, so who has got the data from an entity, to acquaint the entity that has provided the data and make the analysis available for verification and assessment, which is actually a concern that I have. So, these are some postulates included in the EHDS concerning the data for secondary use. And, well, I'm following up on what the professor has said. I believe that there is a whole range of data that could be used by anybody without practically any further preconditions. But then, naturally, work needs to be done before making them accessible, means full anonymization that prevents identification of a person or a specific provider. And I also need to follow up on what Editor-in-Chief of Zdravotnický deník, Mr. Zicker, has said, what benefit it could have for health insurance companies. I won't speak about health insurance companies, but about us when it comes to quality indicators. What we see is that pragmatically, realistically, there is not enough capacity of data analysts who can navigate in the data so well to be able to produce meaningful, utilizable information based on the data. And very often colleagues from the academia argue and they say, well, no wonder there is a lack of people when data are locked and it's very difficult to access them. So if partially the NZIS data could be open to anyone, including the academia, the benefit for us would be that there would be multiple experts, multiple people, multiple analysts who would be able to work with the data and would be able to enrich public administration as a result.
What is the precondition for using the data in the Czech Republic? First of all, it's not about data only, it's about motivation and competition to use it. Why do we need the data if we find out that the provider, in fact, the quality indicator shows triple worse result compared to others if in the subsequent meeting we are told that nobody is able to do anything about it, that the health insurance company cannot decrease the reimbursement or cannot work with that. If the information is somehow lying in the Ministry of Health for another year, and patients are dying in the meantime. So we need to be able to process the data correctly. So that's why I feel that for correct routine data usage, it would also need immediate implementation in the key core processes, meaning planning the scope of the services provided and indicators to evaluate the quality. For this purpose, it will be necessary to reset the motivation, and this will allow us to improve the system from partial project to the agenda. And I'm so pleased that we understand and agree with Professor Dušek. We always state that the project management of agenda is not an ideal approach, so the data should be always transferred to the decision makers, for instance, the health insurance companies or Ministry of Health, that will allow us to really implement this system using evidence-based data, and in fact political drifts of the system will be reduced, and we will rather implement the objective-based data management, objective-based analysis. Ladies and gentlemen, thank you very much for your attention. Thank you very much. So I will ask my question later on. Nevertheless, I would like to ask my question first to the Deputy Minister because he has to leave. It was a question for everybody. You can think about it later on. Is it correct that once all security requirements and so on, as many as entities would be able to access the data, or should we exclude certain entities, or should it be simply open to everybody who is interested, provided they comply with all the preconditions? Of course, the answer is easy. No entity should be excluded, but we still should consider the purpose of data usage, for which purpose those data can be used or should be used. So we should not exclude, let's say, the patient organization or the industry. Being in certain position, it does not mean that we should reduce the accessibility. But in fact, what is quite widely discussed, I don't think that we should open the data for all the purposes. Definitely, we will just set certain limitations. For instance, speaking about data entry of certain information and of course, all the applicants should comply with all the requirements. Nevertheless, speaking about marketing usage, yes, we can talk about regulation in the other stages and so on. It will depend on the price, of course, because I think that once it benefits the public interest, then the preconditions should be slightly different compared to data used for business usage. So the pricing will develop accordingly. It should be purpose-driven access, and of course validation access is also required. We have discussed it with Professor Dušek a lot. So the raw data developed, generated in the system cannot be used for marketing purposes, communication. We should verify the interpretation and so on. It is about data that will be published. In fact, are those data already adjusted, modified? No, it is not possible to do it like that, to prepare the data in such mode that it could be used without a subsequent review involving interpretation of those data. I think it is not an easy task to generate data in this form. Maybe I would like to share with you one example. I was thinking about vaccination, and I forgot what was it? Autism in children. There is one clinical trial, and still we are experiencing the public voices driven by this idea. So there is potential abuse of the data, so nothing helped. So once the data about the autism of children triggered by vaccination was published, so it was MMR vaccine, and in fact there are dozens of thousands of people who trust this nonsense. Thank you very much for coming, for joining us. I know you have to leave. So in the moment, once data are published at the level of individual line, you have no possibility to get back the data, the published data. So what we need to prepare prepare data protection and of course data quality. So we need to use not only primary data, but we need to be able to adjust the quality of data. So I hope I will not contribute to your depression. what the Vice Minister had warned against. It's a reality, and it does not make sense to precondition anything by that. I cannot imagine that we would establish an authority that will just filter information provided by entity A to entity B and so on. I cannot imagine that once I'll transfer data to one organization shared by 50 staff, let's say, then maybe they would share data with the other institutions. We cannot eliminate the situation when the situation or information would be abused in media. I hope that we will never experience again the situation that we experienced during the COVID pandemic. Who is to blame? An industry or somebody who develops the ideology? To what extent academics contributed to this situation. In fact, I was the only one who was asked, and nobody had done anything about it. We cannot eliminate such abuse of situation, and we should not, in fact, condition the development of data by this potential abuse. So I cannot imagine that we will release the data with the office-driven control of the data, focusing on the future purpose of usage. It's hard to achieve it. Then there will be a lot of people working on it with high authorities powers, and I don't think it is feasible in the Czech Republic. So we should speed up before the new epidemic breaks again. So, Mr. Director Švec, I know that we have already discussed it. Nevertheless, I would like to repeat it. So, should we make the data accessible to everybody or to selected authorities only? Should we precondition it by some parameters, criteria, good, relevant site where everybody can view the data with comment, knowing that the data quality is guaranteed there, so they would learn that they would contact this single point of contact, guaranteeing the quality. Well, I don't know whether we can guarantee the high quality data at all times. So, of course, data exists somewhere. So we should ask ourselves whether the data or data analysis was in fact driven by the methodology of processing, whether the data collection was done in appropriate manner, whether we can verify the outcome. And that's exactly what I like about the EHDS system. The truth is that once the data are published, then we can no longer influence it. But what the EHDS regulation regulates is that the data has to be accessible based on the this or that verification, and this would guarantee, in my view, filtering only high quality data. Speaking about making the data accessible for everybody, then we have to distinguish between individual levels of granularity of the data. Do we want to filter data relevant for a specific hospital, a specific period of time, or do we want to monitor patients over a certain timeline? Speaking about data scope, we need to, of course, underline it by the anonymization. Thank you very much. What I really like is that scientists declare that correct data cannot be declared correct always, but that's the trouble in media world. But it would require a long discussion. Of course, we just would like to hear that maybe it's not 100% correct, but processed to the greatest possible quality. It is always a process of cultivating the environment. Yes, of course, but the media articles or TV shots happens at a certain period of time. So I just wanted to show the contradiction of media and scientific world. Let's focus on the health insurance companies. Focusing on data currently available or data that could be made accessible and to whom, and is it linked with an inspiration, what we had heard in the presentation of our guest. So are you interested in the data provided by health insurance companies when you decide what treatment line should be adopted? So maybe at the beginning, I would like to share with you that we have received the information developed by the Association of Innovative Pharmaceutical Industry today, and they are talking not about secondary data, but also about the usage of primary data. And the goal or the ambition is that the primary data and its usage, of course, using the secondary data also, should increase the information knowledge of the patients. And I guess it is high quality. Second, it will improve the quality of care. I'm not quite sure about it, because then you would have to stipulate really strong motivation mechanism to achieve that. Because, for instance, speaking about e-prescription, we can see that we are able to monitor what the patients were prescribed, what drugs, but do we know whether the attending physicians are also monitoring that? The third goal, decreasing the cost for the health insurance system even by 15% in hospitals, it's a fiction. Of course, cost for healthcare will be increased at least by 2 to 3% more compared to our ability to generate machines, and we would have to face it. And then we would have to be in the situation when we'll admit, yes, of course, the cost had been increased in 5 or 7 years. It doubled. But without those mechanisms, maybe it will be increased even more by half of it. And those are soft measures that we can or don't have to trust. So speaking about health insurance companies, they are doing whatever they can with data currently available. We have also opened the Health Insurance Bureau, and we plan to cooperate more with the Office of Health Insurance and Statistics. And what is, however, not right yet is the competence and timeline to be able to develop relevant results out of the data available. And we have to make it happen, because without that, who would guarantee that the hospitals would manage to save 15% of their cost? And then, of course, we can ask about the relevant tools and how to use those relevant tools. But unfortunately, health insurance companies are in the situation when they are finding out a lot of those aspects. Nevertheless, to make sure that those criteria will be implemented into individual contracts with providers of healthcare, creating motivation to modify the health care provided. It will not happen over 1 year. It's a stable, quite large task for responsible institution to work on it. And I think we are, I don't want to say we are in the 0 stage, we are maybe in -1 stage. Director Benešová, what health insurance companies may share based on your experience, what they are able and willing to share, and do you also see and use the data from the providers, and how would you able to use them?
Naturally, the data that we have at our disposal, we strive to process and aggregate to be able to use them and, for instance, then interconnect the data with preventive programs, screening programs, and keep motivating our clients when they are, not entitled, but rather obliged to do something about their health so that their health improves. We also strive to use the data that we take part in evaluating in the Health Insurance Bureau when determining, for instance, the contractual network of hospitals. We highlight that the individual procedures need to be centralized, especially, there needs to be centralization when it comes to diagnosis that have been mentioned here during the discussion. And now, let me ask one more question from the audience. Mr. Tichopand is asking whether my apologies. I have now lost the question, so terribly sorry, really. Oh, yes, here it is. How does VoZP, or does the VoZP consider it to be beneficial to measure the quality of provided healthcare and also vis-a-vis, using data from the real world? This is a difficult question to answer. So I must say that I personally believe that indeed there should be as much interlinkage between the provided data as possible. But now perhaps let me return to an earlier asked question, whether everything should be accessible for everybody. I have a big problem with that. Because at one point in time I was flooded with a lot of questions. The problem is that the party or stakeholder asking doesn't really have an insight into what it's asking about. So really there has to be information about the purpose. When it's relevant, I'm not against providing the data, but sometimes I have a big problem with providing the data. And also there can be some issues in the provided healthcare data. For instance, our clients have access to information about the cost of treatments, and we are interested in the feedback from our clients, whether perhaps this may be motivational for them to avoid, for instance, certain treatment or not. And now when pharma companies want data for the purposes of adding a new medicinal product on the reimbursement list, would anybody like to take that question? If I may, when I follow the situation, we in most cases actually do provide the data for this purpose. But first it has to be statistically significant data, so no risk of for instance, the privacy of the individual. And then the question is whether we may need to, in some cases, alter the collection of data, because sometimes it's really not possible to provide that information, or it would be meaningless for the applicant. Thank you very much. There are also some questions and comments from the audience. The comments are that EHDA and EHDS is a good way forward. So, for instance, in public health, it's vital to work with the data analysis. The RIA should be based on data analysis. EHDS is the right way forward. So a couple of comments. But now let me hand over to Executive Director, Mr. Kolář, to respond to what has been mentioned here. As regards the 15% saving, so these figures were published directly by the European Commission. So that's their information. So, for instance, avoiding duplicities in screening and various examinations, etc. So that should be a question directed to the EC. Rather, it's in their official documents. So it was published by the EC. But let me follow up on this general question. I do agree with what the Deputy Minister has said. So it really doesn't matter what entity requests the data, but it's rather the purpose that matters. And we mention it in our position paper when, for instance, it would be an obligation if for instance, a drug is to be included on the reimbursement list, what economic benefits there would be, etc. The data should be used because it would be a win-win situation for both sides. So this has been mentioned, and I really do identify myself with that view. And as regards the question of marketing, it's somewhat broader. So what is advertising? What is marketing? What is provision of information vis-a-vis doctors, the regulator of patient organizations? This part, I believe, is an area where Europe is lagging behind, given how the digital sphere has been developing. And as has been mentioned by Mr. Švec, data is going to flow through the system, and if broad audience has access to the data, and this is the right way forward. If data security is ensured, anonymization is ensured, there is naturally a risk of misinterpretation of the data. It may have a negative effect. One way of mitigating this, not stopping it altogether, would be to strengthen data literacy in the health arena, but still it can't be fully prevented. However, still, we shouldn't prevent making data accessible to a much broader extent than to which it was accessible up to now for that sake. Thank you very much. And now just two last questions. Let me pick out of those questions that have come to us, and then I'll ask the MEP for some final summary or concluding remarks. So let me ask this question. So this is a question to Mrs. Švecová from ÚZIS. So somebody from the audience is saying that giving bonuses to doctors for treatment is inspirational. Has this system of bonuses to doctors been reflected in the quality of healthcare? The floor is yours. So how have the data had an impact on the quality of healthcare? Well, we collect data from our clients. It's their subjective perspective. They only evaluate the provided healthcare. It's their subjective viewpoint. We naturally monitor what doctors have been thus appreciated by the clients, but we don't make any statistics out of that. And when the client actually has decided to give a bonus to that doctor, then yes, we really do provide some financial remuneration to that doctor in the end. But it can naturally be motivational for the doctors that, yes, this bonus system motivates them to keep providing high quality of care. Thank you very much. And now one other question. In the Czech Republic, there have been a couple of initiatives in place when it comes to data provision. So, for instance, lab results reported in the National Register. However, the actual implementation is being blocked by a lacking infrastructure. Yeah, should we focus on this aspect and not wait for the EHDS? I see you nodding, so Professor would like to respond. Well, yes. Well, nobody is waiting for EHDS. This has come independently of that. And the person asking the question is right. So when it comes to the lab system during the COVID pandemic, the impossible has become reality. So providers are connected to one engine, and thanks to a B2B system without redundant human intervention, it does work, but unfortunately it works only for one diagnosis, and that's COVID-19. We are cooperating with professional societies for this to extend further into other lab tests and other diseases. So what was born under a lot of stress, it should be utilized and developed further. So what constraints are there? It's not really the infrastructure and it's not the lab segment to blame, but rather the definition of content is at stake. So let me quickly tell you how I'm getting to the end of my presentation, and we don't have the codes, we don't have standardized reporting methods versus results, and we can't basically come up with a regulation and collect data, because we would only be collecting bytes of information and nothing else. So we are communicating with a number of professional societies, and it is in the pipeline. So probably surveillance of infectious diseases is going to be expanded. So labs are going to report into the system, and it's also going to be reported to health insurance companies, because it's nonsensical that health insurance companies can't see lab data. Nobody has ever explained to me why it's not possible to see those data. And then it's going to be spread in areas where it's most possible. So diabetology, cardiology, etc., where data is of utmost importance. I hope that I've made myself clear, but it indeed should become reality and not the latest. Perhaps Mr. Švec would like to add something to it. When we're speaking about the EHDS and its relation to our national regulation, I am almost absolutely sure that in the Czech Republic we haven't managed to systematically finalize a number of things, because many of the agendas are highly complex. And we have this peculiarity that things tend to be mistrusted, rejected, etc. when it's a proposal that comes from the Czech Republic. The added value of European legislation is that when it comes from Brussels and it's directly applicable, then everybody from the Czech Republic keeps his or her mouth shut and says, yes, we need to make it happen. That's the added value of the good things that come from Brussels. So when they do come, then they are implemented subsequently. Would anybody else like to respond to this topic?
Okay, one comment only. I also feel that the European regulation, once published, will improve the perception and will, in fact, make a floor for better understanding. But today we are really impatient, waiting for the e-request, waiting for the e-discharge record, and once we get the data better in time compared to the reimbursement billing, notice, then we believe that the health insurance companies would be able to improve the cost effectiveness of certain action. Well, I don't want to be pessimistic. In Germany, the minister had ordered to develop e-recept by the end of the year as a mandatory requirement. So I would say a lot of things are going on, and we can talk long about it. So on a positive note, I would like to ask the member of the European Parliament, Mr. Knotek, for a final speech. Thank you very much. Before we say goodbye, I would like to react to a couple of things that were discussed. Speaking about IT infrastructure, should we wait or not? Yes, definitely we should not wait. And this is also my understanding. Money, funds provided by European Commission allocated for the launch of this product. First item in the amount of about 800 million euros should harmonize different computing engines in 27 member states, and then up to 12 billion euros in the eHealth category. So we plan that European states will just use funds currently available, and then who should participate on processing of secondary data. Always professionals, private ones or state administration. I cannot imagine that somebody will come to the computer Saturday afternoon and will start computing, processing data during the weekend instead of watching some sport match. So it should always be a motivation for all the stakeholders, IT specialists, physicians, mathematicians, biochemistry staff, and so on. So, of course, if you download first chart and evaluate it and post it on social media, then if published by somebody with higher ratings, with high impact in the media, it can be really destroyed. It's about a learning mechanism also. Speaking about 115 million, so I just wanted to tell something funny, but I just wanted to say that not all data as of European Commission is so tuned up. You can think that 30,000 employees is able to develop something with high quality, but it is not always like that. I would like to thank Zdravotnický deník and Media Network, all experts for all your work, for all your effort, your competence and abilities. It shows how far we are from the reality, and it's really good for us to attend roundtables like today, which will improve our understanding. And in fact, it will allow us to stipulate a better framework. Based on today's discussion, I dare to say that working with secondary data makes sense, increases the better usage for the future. It's a good development, and that's why it makes sense to have the European health data space. Of course, it has to be transparent, and it makes sense for Europe to standardize the format, which will improve the care. It will harmonize level of care provided in individual member states. So again, thank you very much for your attention and for your question. Have a nice day. Okay, I would like to thank everybody. I would like to thank IKEM and Professor Haluzík for hosting us. Thank you very much. Have a very nice afternoon.